it's Dr. Towfigh. Welcome to Hernia Talk Live. I'm your host, Dr. Shirin Towfigh, joining you every Tuesday on Hernia Talk Tuesdays. Thank you for logging in, whether you're here as a Facebook Live on Facebook with me at Dr. Towfigh or via Zoom. Thank you. And thanks to everyone who follows me on X and Instagram at HerniaTalk. Remember, this and all prior episodes will be hosted on my YouTube channel at HerniaTalk. And also, if you prefer the podcast option, then we have that. Hernia Talk Live is now available as a podcast. Please do subscribe and like. And the more you do that, the more people are able to find it when they're searching for somebody to hear on a podcast. So I thank you very much for that. So today, we're going to talk about mesh fixation. It's something that we've alluded to in prior episodes, but we've never really looked at it, talked about mesh fixation on its own. And just a quick brief overview. When surgeons use mesh, they implant some type of barrier. It's usually a sheet, although it can have a three-dimensionality to it. And that sheet needs to stay wherever it is that the surgeon is placing it. If you'd have a non-mesh repair, it's usually a closure of your hernia. A hernia is a defect, it's a hole, so you close the hole. However, there's nothing in addition to your own tissues that's involved in a tissue repair. It's your own tissues, hence the name. However, if you undergo mesh repair, which is the dominant type of repair over 90% in the United States, and it's not necessarily, it's very regional as to how much mesh is used outside the United States. Most first world countries use mesh repairs. Most third world countries do not use mesh repairs because mesh is expensive. And they both are suffering from consequences of that decision. So the people that live in first world countries have are subjected to mesh-related complications, and the people that live in third world countries are subjected to these horribly large, complicated, deforming hernias that prevent them from being active and making a living. So it's you gotta tailor it, is what I always say. So specifically talking about mesh fixation. So it used to be that we thought that once you put mesh in place, you had to sew it in place for it to stay. And then that way, let's say you want to put mesh over a hole, right? So you want to make sure the mesh is perfectly centered over that hole, and then you would put some type of fixation to prevent the mesh from moving away from that hole. And that was part of the whole idea of improving outcomes from mesh repair, is to make sure the mesh stays exactly where you intended to place it. Now, over the years, I would say since the 1980s, we have gradually moved towards different types of fixation and also less fixation, because the techniques have changed and the type of mesh we have has changed. So current day hernia repair, you should talk to your surgeon about how they plan to fixate or not fixate the mesh. Mostly for your own education. I don't think it's appropriate to ask your surgeon to fixate or not fixate a mesh because that's how you want it. It may or may not be appropriate for your type of repair, or your surgeon may not be doing the right technique where you can kind of fixate or not fixate. But the most common way to fixate a mesh is with sutures. You sew it in place. The same way if you put a patch on your outfit, let's say like a ExxonMobil patch, or like a cute little picture, like some type of sequin or something, you will sew that to your outfit. The same is true of most types of mesh fixations, which is they take a little needle and thread, what we call it a suture, and your surgeon will sew the mesh in place. And that can be done with either what we call interrupted sutures. So you basically little darns tacking the mesh in specific areas, or what we call running sutures. So we basically sewed all along the edges of the mesh. And then the second question is, okay, now that you've fixated with suture, what type of suture? Most mesh fixation technique, if the mesh is permanent, is done also with permanent suture. If the mesh is absorbable, usually we also do it with absorbable suture. It doesn't make sense to use permanent suture for absorbable mesh, because once the mesh is absorbed, why do you need the suture to be there? That's typical. However, there are some surgeons that you prefer to use absorbable suture for permanent mesh. And there's been varying results in that. In my opinion, that's subjecting patients to slightly higher risk of hernia recurrence, because once the fixation is gone, if it's a type of repair that demands fixation, then you may have a hernia recurrence because the mesh starts shifting over time. And by over time, it means like years, not immediately. But other surgeons feel it's just as good to use absorbable mesh, absorbable suture with permanent non-absorbable mesh. So I've seen both occur by perfectly trained, well, gifted surgeons. So that just goes to show you there's different ways of treating the same patient. Once we moved to laparoscopic surgery and laparoscopic hernia repairs, we started moving away from suturing techniques because, frankly, it's difficult to suture. There are surgeons that do really good job of suturing, and it doesn't matter to them if they're doing it open or laparoscopic. But most surgeons do not know how to do a good suturing repair. And for inguinal hernias or laparoscopic ventral hernias, the angle at which you need to sew is a little bit difficult. So the tacks were invented. Tacks were invented by industry to meet the needs of surgeons who could not basically do their hernia repair because they couldn't suture in the mesh. So what are tacks? Tacks are some type of like nail or screw type fixation method. It's not truly a nail or screw, but it's kind of the same concept where you're tacking a mesh in place. That nail or screw type design will then push and hold the mesh, usually into muscle or fascia, sometimes into bone. And we start moving away from suturing when we're doing laparoscopic surgery because now we have all these tacks. So that's how we did it. Then we got robotic surgery, and robotic surgery added a whole different realm of fixation methods. So some people still use the tacks that we use laparoscopically. They still use it robotically. That's not what I recommend for my own patients. For my patients, I go ahead and go back to the old-fashioned suturing method. So the same way we were suturing with open surgery for hernias, suturing the mesh in place, robotically, I also suture. It's much easier to suture robotically than laparoscopically. So I do go back to using robotic suturing. Again, you can suture continuously, or what we call running, or in interrupted fashion where you kind of put little darns in place. And you can use absorbable or permanent suture depending on the type of mesh and the type of repair. Glue was kind of cool for a hot minute. This was initially used for the groin and inguinal hernias, where instead of suturing laparoscopically, we were using glue. I was doing that for a while. Then we found out you can actually probably just not use anything, so why use glue? And then for open surgery, there's a great trial that glue may work, done by the group of Campanelli in Italy, the Tamelli trial. We actually, when I was at USC, initiated an animal study to see if gluing works for the ventral or abdominal wall hernias. In terms of stickiness, it didn't work as well. And so no one was really gluing the abdominal wall hernias. And then now we've graduated to meshes that stick on their own. So there are meshes that have these little like Velcro grips. They're called Progrip meshes. Oftentimes you don't have to fixate those at all because once you put it in, it already sticks to where it needs to be. And they don't tend to migrate very much. We've learned to put meshes in certain areas of the body where it sticks better. So if you sandwich the mesh in between layers of tissues instead of just putting it on top of a layer of tissue, then that sandwiching alone can help hold the mesh in place, and you either need very little suturing or no suturing at all, because it's like putting a letter in an envelope, right? You don't need to staple the letter to your envelope. As long as it fits perfectly in the envelope, it'll stay in your envelope until someone takes it out. So that's the other technology, and there's some newer technology. So I actually saw some really cool idea coming out, which is it's a mesh that has glue on it, but that's been used before. It doesn't work very well. But now they came up with a mesh that has glue on it, but the glue is inactive until after you place it in place. And then once you place it in place, there's this like blue light that you can shine on the mesh, and that activates the glue, and then it glues in place. It's kind of cool. In general, we've learned over time that the less you fixate, the less pain people have, because they tend to hurt where there's sutures or tacks for fixation. Also, the less you fixate, the kind of more natural the mesh will lay. You're not forcing it to be fixed in certain areas. And lastly, we've learned it's better to have the entire surface area of the mesh adherent than the individual areas where you put the sutures. That's why the Progrip mesh has been such a good product over the years. So going back to the Tacks, similar to sutures, they are both absorbable and non-absorbable. I tend to use the permanent non-absorbable ones the same way that I use the sutures, non-absorbable. And then if there's any way that I can do any hernia without fixation, both inguinal and ventral, I do prefer the not fixating the mesh. And I always tell my residents, you know, you gotta be a really good physics person. So it's all about forces and vectors. I don't know if any of you like enjoy physics, but I really liked physics. I understood it very much. Not enough to be an engineer, but enough to be a good hernia surgeon. So in order to be a good hernia surgeon, you should understand how the different forces and vectors are applied when you do abdominal wall repair, and then apply your fixation, for example, accordingly. So I'm going to slow down here and kind of answer some of your questions. Here's a comment. I had a small inguinal hernia surgery, and the doctor put a mesh plug and patch in me 9 years ago. I've had a horrible pain for 9 years, and I was told my mesh is over my pubic bone. I have 3 more hernias, but I'm afraid to have surgery. So that's a good point, which is if you have a mesh plug, which we don't recommend anymore, but for sure there are tons of doctors that are still using mesh plugs, but it's still a very commonly sold mesh. But let's say you do use a mesh plug, it is a very three-dimensional product. So if you put that into a hole, you want to make sure that it fits into the hole perfectly. I'll give you an example. If you have a wine bottle, right, and you have the cork in the wine. I'm sure there's a better name than cork. If there is a better name than cork for wine bottles, let me know. So if you take the cork out, you want to push it back in. You can't push it in like at an angle. It has to go perfectly parallel to the mouth of the wine bottle for the cork if you want it to fit. The same is true about a mesh plug. So you want it to be perfectly perpendicular into the space, and you want it to stay in that location. A lot of people involved in the mesh lawsuits have been told that about this concept of mesh migration. Well, For most meshes, there is no such thing as mesh migration. I've had patients come to my office and they're afraid they have mesh in their eye, they have mesh in their brain, they have pain in the upper abdomen, even though they had mesh in the groin, they think the mesh has migrated to their liver. That doesn't happen. However, mesh plug, if it's not fixated securely in place with at least 3 sutures, that mesh can rotate or move around or migrate. So why 3? Three prevent, remember, it's a 3-dimensional product. So it's kind of like this glass, right? It's 3-dimensional. So if you're going to put this glass into a hole or put the plug into a hole, if you only put 2 sutures, it's going to rotate along that axis. So if you put 3 sutures, like a triangle, it will prevent the mesh from twisting in itself. Again, physics. So now that you have one of our viewers who's always shows up, thank you very much. I'm very honored to always have you and hear your story. She's saying that she has a mesh plug, but it's on her pubic bone now. So it's possible that hers actually rotated and now is in a very painful position over her pubic bone. Okay, here's another question. I had a laparoscopic inguinal hernia repair with non-absorbable mesh. My mesh was attached to the Cooper's ligament with 2 tacks. Could attachment to this ligament cause pain? No, typically not. So, couple of things about tacks. So tacks they're like usually like screws. They're these spiral screws, or sometimes titanium, sometimes plastic, and those are placed in areas. When you place them laparoscopically into Cooper's ligament, often they don't put it in the ligament, they actually put it in the bone. And depending on certain people and how they respond and how deep in the bone it goes and whether it's being tugged on, yes, that could cause pain. Just tacking into Cooper's ligament itself should not cause pain, and we do it all the time. It's actually the correct technique to do. To put 2 tacks in Cooper's ligament sounds like usually the right thing to do. But if you have, 5 tacks into Cooper's ligament, or 20 tacks in your abdominal wall, that's a bit excessive. Next question. What determines which inguinal hernia laparoscopic repairs need fixation? In my case, you will you need to use tacks? So yes, depends on the type of hernia. So for your typical hernia, indirect inguinal hernia, not a very large one, you laparoscopically place or even robotic, you do not need to secure the mesh. As long as you develop a good enough area, like your envelope, to allow for your letter, which is the mesh, to fit in there perfectly and flatly without a wrinkle and in perfect size, then when you close that envelope, i.e. the space you made for laparoscopic or robotic repair, that should hold the mesh in place. And these are flat meshes we're talking about. However, there is, so that's only for indirect inguinal hernias. For a femoral hernia, the issue with femoral hernia is, number one, you want to make sure when you fix a femoral hernia, it doesn't recur, because it is the one hernia that actually has some type of death rate associated with it that's significant. So you want to fix a femoral hernia because you're saving someone's life by doing that. And the difference between femoral hernias and other hernias is when you repair them laparoscopically, the amount of mesh overlap is less than for the other hernias. What does that mean? Let's say we do an indirect inguinal hernia. You usually have 4 to 5 centimeters of mesh overlap on either side. With a femoral hernia, you may have 2 centimeters, so about half of that. So if there's any shift of the mesh to left, right, up, or down for an indirect inguinal hernia, you're still fine. Like, you're not going to shift 4 or 5 centimeters. There's not that much space for the laparoscopic mesh. However, You can imagine 1 or 1.5 centimeter shift of a femoral hernia will then make it so the the mesh doesn't adequately cover the femoral space, and you'll get a femoral hernia recurrence. So for femoral hernias, again, physics, I do fixate the mesh to Cooper's ligament, which is the lower border of the femoral space, to assure that the mesh does not flip up or shift upwards and expose the femoral hernia. And that's my routine. I think it makes sense from a physics standpoint. Direct hernias is a different situation. Most people with direct hernias are older and or by definition have a weakness in their muscle. It's called the transversalis muscle. It's your inner girdle. So when you stand with a direct hernia, you have a bulge. Even small hernias, you have a bulge. And what happens is the bulge is not necessarily a hole, although it can be. But more typical for a direct hernia is a weakness of the muscle. It's just pooching out. So if you have that situation, and you put mesh, you don't want the mesh to be dragged by that direct hernia and pooch it out, right? What's a good analogy for that one? I'll have to figure out that one because I can make a clothing analogy, but it's not a good clothing analogy. So what you want to do with a direct hernia is to take that weakness, tighten it up, make it flat, and then put a nice mesh on it and also secure the mesh. Again, triangulate in three positions. And the whole point is for the mesh not to billow into the direct space. So you may have a weakening of that space, but you want the mesh to be flat. I just saw a patient what's today? Tuesday, yeah. I saw a patient this week that actually had that. So it's very interesting. He had a direct hernia, which is a bulging. And then he had a mesh repair, but the mesh is very flat. Now, what they didn't do, which I wish they had done, is they didn't taper down or plicate or tighten up the weakened direct hernia muscle. And because they didn't do that, if we got an imaging on it, you could see that his natural state of his pelvic floor at the direct hernia, the natural muscle state of this weakened transversalis fascia is for it to bulge. So he has a bulging area of muscle, but it's not clinically relevant because deep to it, the mesh is flat and doesn't bulge into it. And probably that's because they did a good job of fixating that mesh. Otherwise, the mesh would fall into that bulge. And many people who have direct inguinal hernias that are repaired are unhappy because either A, they see a bulge still, B, they or B, they have pain because B, they have pain because the mesh wants to fall into that hole and it's tugging. Or C, the mesh falls into the billowing with certain activities. So let's say my favorite story is the one I had a lady, she was a grandmother and she would go to her grandkids' soccer games. And she's like, every time I'm out there yelling at the kids, I get this groin pain. But it's because you're increasing your abdominal pressure. When you're increasing your abdominal pressure, you're pushing hernias out. If you had a good hernia repair, that hernia repair would be a blockade to the otherwise weakened muscle that's trying to push out. It would be like a wall. What you're doing is a curtain. That's a good analogy. Okay, that's a good analogy. I like that. So what you want against a weakened direct hernia is a wall, and that's your mesh. What you don't want is a curtain so it just follows the weakness of the mesh. And when you flip that wall, you want it not to break away because it's not a very thick wall. So you want to fixate in at least 3 places to prevent the mesh from falling into it. A lot of surgeons don't understand that. A lot of surgeons are not good at physics, and therefore they treat a direct, indirect, femoral all the same. And they pride themselves in doing mesh repair without fixation. Listen, I do mesh placement in the groin without fixation, but not if you have a big weakened direct space. That doesn't make any sense, because it's just going to mean that your mesh will fall into that space. You told me to go see a good doctor that was going to Rochester last December. I forgot her name, and my son said to ask you again for her name. He lived in Rochester. I also have 4 more hernias I'm afraid to have fixed. Please tell me the doctor's name again. Thank you so much. Wish you would come to Minnesota. Oh, well, thank you very much. Actually, since the last time I spoke with you, the doctor I told you has left and there's a new doctor. But you're lucky because I have also interviewed her. Her name is Dr. Charlotte Horne, Horne. She works out of Mayo Clinic now, is now the dedicated hernia surgeon at the Mayo Clinic, and she'll be a great person for you to see because she's gifted and she would be able to definitely help you out at the Mayo Clinic. So best of luck there. Okay. Another question I see. Will Progrip address the direct hernia billowing you described? No. And is there a risk of adhering to spermatic cord of the Progrip? So, good question. So I just talked about Progrip. Progrip is that mesh I told you that has a little grips. It's like Velcro. So it works great on a flat surface, right? So if you take anything that has a flat surface and you Velcro something to it, it'll stick. So if you have a hernia and you clear the hernia and you close the hernia, let's say for a ventral hernia, or it's a small indirect inguinal hernia, then you can use a Progrip and it'll stick exactly where it needs to go. However, for areas of weakness, you either tighten up the weakness or the Progrip will, or you have to suture in place the Progrip, and you have to suture in place the Progrip, excuse me, because it doesn't do the Progrips, the grips of the Progrip mesh. The grips don't work if it's just what we call bridging. So if it's not stuck to anything, it won't work. So you don't want it stuck to like just bridging. And the issue with billowing is still there. So if you put the Progrip onto a direct hernia and there's a weakness there, it will stick to that weakness and just billow out, and that's not good. So yes, in general, the Progrip is a great mesh. It stays in place where you want it if it's on a flat surface and it's not bridging. If it's bridging a large gap, you need to A, prevent the bridging, but B, if you can't, fixate the mesh so it doesn't fall into the bridging. And B, if it's over a direct space, which is a weakness, you either have to tighten the direct space, but in addition, you have to sew it in place so it doesn't have that tendency to fall into a hole. Is there a risk of adherence to the spermatic cord of the Progrip? Not as much as typical meshes because those grips are actually absorbable. So they initially grip and then over 3 months or so, those grips are gone. So the Progrip is actually a really good design because of that. And I don't see as many complications requiring mesh removal with the Progrip mesh as I do with the non-Progrip meshes. Let's see, a lot of talk here. I need a good surgeon in SC, that would be South Carolina. All the ones around me are not experienced enough. Actually, South Carolina has excellent surgeons in Greenville. If you go to Greenville, that team has really good hernia surgeons, many of them. Let's see. I would love to chat with you. I have a support group for women with complications from tram and deep flaps. We are very limited to surgeons who can repair us. This is true. Many surgeons have done just basic repair that doesn't work. Can we please chat? Yes, absolutely. I would love to be involved with that. So this is a comment from someone who runs a support group for women who've undergone tram and deep flaps. I know that I've talked about tram and deep flaps, I believe with someone recently. If you Google, let me take that back. If you go on YouTube and you search for tram and deep, DIEP flaps, our HerniaTalk episode may come up because I know I put that in as a keyword. However, what can happen with tram and deep flaps is these are basically muscle flaps, skin and or muscle flaps that are taken from the abdominal wall to help fill deformities in the breast after a mastectomy, usually for cancer, sometimes for prophylaxis from cancer. So in those patients that undergo tram flap, and there are not that many tram flaps anymore, they've switched, the plastic surgeons have switched to deep flaps regardless. With the tram flap, the RA part of tram, TRAM, means rectus abdominis. And the rectus muscle itself is gone in that section of the abdomen. It's quite deforming, or it can be. And I remember when I was a resident, they would say, oh, you get a tummy tuck as part of your tram flap. Look, what a great idea. But what you're really doing is getting rid of one of the muscles. So you're obliged to have a tightening of the muscles because you're missing half your muscle on one side. So when those fall apart, or if they're not done correctly, or whatever the situation is, you can have a very deformed problem. Even if they're done perfectly, the site that's tightened up often stays tight. And then you have natural, if it's only done on one side, you have a natural laxity of the abdominal wall as you age. So actually the other side that was not tram flap now starts bulging, and the side that was tram flap is tight and it looks very odd. So half your belly is bulging and the other half is not. And there's ways to fix it, but you have to be very cognizant of what was done originally. The deep flap, DIEP, is an improvement over the tram flap, primarily because you don't use the muscle. You know, who needs muscle in their breast, right? You just need skin and fat. So in order to recreate this another breast for people who lose their breast surgically, you can take skin and fat from the abdominal wall and then transfer it over to the breast and make a fake breast, basically. That is an interesting and much less problem with that procedure than the tram flap. However, what they try and do is to pick out good blood vessels that they can use to reattach to make sure that that flap is healthy and gets good blood flow in the breast. And in doing so, sometimes they're in the wrong location, or they end up causing damage to the nerves. If you cause damage to the abdominal wall nerves, what can happen is you can actually get rid of the nerve in that region. And what happens is you start bulging in the area. So for example, you can have a perfectly good deep flap for your breast, and then within a month to 3 months after surgery, you'll be like, why am I kind of bulging? And it's usually on one side. I've seen a couple deep flap complications where it's on both sides, but usually on one side. That denervation injury is very difficult to treat. You can never bring the patient back to completely normal, but there are tips and tricks on how to reconfigure the abdominal wall with mesh. Can't do it without mesh, but with mesh to tighten it up to make it seem more flat. And then lastly, they can actually injure the muscle in the wrong plane and injure and cause a hernia. That's less common. Those are relatively easy to fix. The hernias from the deep flaps are relatively easy to fix. Let's see. I'm Mickey from England. Hi, Mickey. I've Recently had a colonoscopy, which showed mesh coming through my bowel from an old hernia. The surgeon says he doesn't want to operate. I'm worried I'm a ticking time bomb as I can see the mesh on the imaging. The sacred tissues has covered the other side of mesh. Can it burst? Shall I leave it alone or go for surgery? Hello, Mickey from England. I'll be in your country in less than in about a month. Looking forward to it. So, had a colonoscopy was showed mesh coming through my bowel from an old hernia. Okay, hold on. So you're telling me your GI doctor who did a colonoscopy saw mesh inside your intestine? That definitely should get fixed. Definitely, because the option of not fixing it, and by fixing, I mean someone needs to go in there, take out the mesh, and then close the hole in your intestine. By not fixing it, you basically have best case scenario, a mesh infection, worst case scenario, an intestinal fistula, where you have stool coming out of wherever your mesh is from your skin. Bad, bad, bad situation. I wonder if you had a mesh plug, by the way. I'd like to know the answer to that. Light of Hope, thank you very much. What causes fighting and hardening? Sorry, what causes tightening and hardening? So all implants cause some type of foreign body reaction, inflammation, and fibrosis. We've published that. Doesn't matter why you had the mesh in or what kind of mesh in. Doesn't actually matter what kind of implant. It could be a pacemaker for all intents and purposes. But that foreign body reaction, fibrosis, and inflammation can make it so that the body encapsulates the mesh, scars onto the mesh, and therefore the mesh becomes much stiffer and more shrunken than when it was originally placed. A lot of these meshes, you take it out of the box, it's beautiful. It's like fabric, it's soft, it's got soft edges, it's lightweight. And then you put it in the patient, you come back, let's say 5 years later to take it out, and now it's firm, it's stiff, it's got rough edges, and so on. So that has to do with your body's reaction. Now, there are patients that don't do that. They don't react to implants like other patients do. Some patients react very, very strongly, and it's unpredictable who is going to be that person who will severely react to mesh. But in patients that severely react to mesh and it becomes very hard and stiff and tight, they actually kind of feel the mesh. It's called a foreign body sensation. They feel stiffened by it. They feel restricted in activities by it. Because just think of it, you have a very firm, almost, let's say, cardboard against an otherwise soft, smooth abdominal wall muscle, which, you can look at Cirque du Soleil, gymnasts, they have they're very limber, partly because their muscles are also very soft. But if you put something stiff in them, that's going to be very difficult. Okay, next one. I wanted to thank you so much for your medical advice here. Well, thank you. I was having dysejaculation and systemic symptoms from a TEP inguinal hernia mesh implant. I had my mesh removed by Dr. Brian Jacob, who you received here, and all went well. Well, congratulations. This is fantastic. Dr. Brian Jacob was one of my first 5 guests on HerniaTalk Live back when I first started. I feel much better and got my sexuality back. Great. New York was easier for me because I live in Paris. Your advice here has led me to take this leap of faith and regain my health and morale. Okay, first of all, congratulations. Secondly, thank you for sharing that, because sometimes I feel people get better and then they just leave. And so we're left with only people that are suffering without giving them any hope that they will get better. So thank you for sharing that. And I just want to reread this so it's very obvious This patient had mesh in them, and it seems the mesh was affecting their sexual performance, causing dysejaculation, as well as other total body problems. And those are certainly complications that we see with mesh. And mesh removal done by a careful surgeon who knows their anatomy and is very good technically can help treat that. Don't let anyone tell you you're going to lose a testicle. Clearly, this patient did not lose a testicle or have any other kind of horrible complications like that. Here's another question. Hi, I'm Catherine from Georgia, new here, invited from a friend. Great. So we got Georgia, Minnesota, South Carolina, and Paris, France. This is fantastic. I've had an umbilical hernia for several years, but have been terrified of surgery. What are my risks of not having surgery? Oh, we've discussed this. Go back and listen to my, I think we've had more than one prior episode. One just specifically talking about umbilical hernias, another talking about watchful waiting. So most patients with very little symptoms from hernias that haven't been operated on before do really well. And you should obviously see a doctor to make sure that you fall into that category, but watchful waiting is considered safe in most patients. Thank you. I'm trying to find out what type of mesh I had. The scar tissue is holding in place the outside of the bowel. I saw the image of this mesh. I can send you a photo of this, and the report said I had a foreign body coming through the bowel, which is the big worry. Shall I speak to a new surgeon? Is there anyone in the UK who you may recommend? Not that many in the UK. Not that many. What I would like you should maybe want to consider Dr. Neil Smart. He's a colorectal surgeon. And did I talk to Neil Smart? I think I had Neil Smart on as a guest. Go see the episode with Dr. Neil Smart. But that may be an option. If not, I recommend just do an online consultation with me, and I'll help figure out what doctor can help you in the UK. And hopefully one day I'll be in the UK treating you guys. I'm looking forward to that. Okay, next question. I have weakness and bulging involving my entire inguinal floor, a direct hernia as you described. Would I need non-absorbable tacks, or could I be successfully repaired by absorbable tacks? If you were being treated by me, I would use non-absorbable permanent tacks. How long would it take for a mesh, or not tacks, even sutures? How long would it take for a mesh to reach its full strength and tissue adherence when done through laparoscopy and without fixation for inguinal hernia repair? Good question. So most of these synthetic meshes, which are the standard meshes used for hernia repairs, they say it becomes sticky and it falls into place within the first 3 days. So that's kind of, that's why none of us really recommend that you restrict your physical activities, because the mesh is pretty much stuck within the first 3 days. And then it starts to increase in its strength. For those that shrink, it shrinks usually within week 6. And that's when sometimes if it's put in too tightly, for example, you'll feel symptoms. But it's full strength and tissue adherence depends on the patient and the type of repair and so on. But definitely after about, I would say 3 months, you're out of the woods. When placing tacks in Cooper's ligament in an elderly male with poor tissue quality, how can you gauge how deep to go into Cooper's ligament to avoid going into the bone and periosteum, which may be more likely cause chronic postoperative pain? Well, you go through the ligament alone, so that there's a ligament and then there's the bone deep to it. So it's purely like a tissue plane issue. Is there something that can be done to soften a stiff mesh? For example, massaging the area or physical therapy, and how can you know if it needs to be replaced? Great questions. Okay, so the short answer is yes. The long answer is we don't know. So I do have patients that get a lot of scar tissue, and their pain is clearly from the scarring of the mesh. And I do recommend massaging of the area, and most of them come back and say they're getting better. And what you're doing is you're breaking up the scar tissue that holds or tugs or pulls on the mesh in a certain direction and allowing the mesh to kind of be more in a more natural state. Also, there are patients that actually have a stiffened mesh, not so much scarring to the mesh, but the mesh itself is stiff. That I've had to actually remove those meshes. There's not much you can do. I've tried steroid injections in some of these patients. I have not seen good results with it. Massaging is usually too painful because the mesh is very, very stiff. And it's a permanent product, so I've had to take out those meshes in patients. But those are good questions. Okay, next question. I was wondering about your UK links. Yes. Are you speaking with the Scottish government about this? I've been trying to get them to reach out to you. As you're aware, I run the petition against the use of mesh in Scotland, also trying to create patient pathways for hernia mesh removal. I'm awaiting umbilical hernia mesh removal myself. My weight is an issue for removal, but due to all the health issues, I'm struggling to have surgery. My BMI is 40, which is too much for what she's asking. Do you feel this is classed as too high risk for removal? Sorry for the questions. Okay, so yes, thank you very much. I'm happy to speak with the Scottish government and happy to help. I personally am working on getting access to the UK to help provide expert surgery, mostly in the complicated areas. I'm sure there's tons of patients that can get good repairs in the typical system. I would be someone who would offer expertise for, let's say, mesh implant illness or mesh removals and so on. From what I understand, your Scottish government has provided support for mesh removals for pelvic meshes. I'm not aware that they have yet provided care and support for hernia meshes. We did have a guest here, Dr. Masi Polovic. He has moved to Scotland and is a great resource for mesh-based repairs and complications. However, and he was a guest on our show, I think about a year ago. So he would be someone good to work with locally. I would love to be able to be involved and help. It's like one of my passions. So if the Scottish government is open to working with me, even send the patients over to me, that would be really great. Because that's part of the problem why I'm trying to get to the UK is that a lot of those patients can't get to me. If the Scottish government can help hernia mesh removal candidates, at least initiate a online consultation with me so I can figure out what's going on. And then determining what your needs are, then come sponsor your care to be with me. I would love that. That would be so cool. Alternatively, I would come to the Scotland because you have a very, very beautiful, I guess technically is it a province? I would love that. And that would be something I would be willing to do. First, I have to get my credentialing, and it takes a couple of years, I'm told, to get that through the GMC, General Medical Council. But yes, if your BMI is 40 and you need your hernia mesh removed and you have a hernia still, then you should get weight loss. I mean, you can get weight loss surgery. That would be good for you because then you can expedite your care for your umbilical hernia mesh removal. Let's see. After inguinal mesh removal, I was warned I could get a recurrence. I had a foreign body syndrome, so what would be the good next step? A shoulder repair? Also, any recommended sports to avoid recurrence? Okay, good question. So if you had mesh removal for mesh implant illness, then First, make sure you're better. And then the question is, how can we repair your hernia? Either you have a hernia now or you're going to have hernia recurrence. So definitely do not use mesh again, right? Because you've already shown a propensity to react to mesh. The question is, do you react to suture? Because you at least did suture, and I use permanent suture, and absorbable suture is not first line of treatment. So if you have permanent suture, I tend to use nylon suture because most of the patients that are tested have not reacted to nylon, but they have reacted to polyester and polypropylene sutures. But I'm very curious. So I would first test you against various sutures, usually EPTFE, nylon, polyester, and polypropylene sutures to see what your propensity is to react to them, and then probably pick the nylon suture for the tissue-based repair. And if it's an inguinal hernia, I usually do a Schuldeis. If you have femoral hernia, I do a McVeigh. Sometimes I do a Bassini, but not as often as a Schuldeis. Is it, oh, and then the second part of the question was, do you recommend any sports to avoid recurrence? All sports are healthy and should be performed. They're all good. Is it possible to email you to discuss my case? What is the best email? Thank you. Yes, just email my office. It's info at Beverly Hills Hernia Center.com. All of that's on my website. It's on, which is Beverly Hills Hernia Center.com. It's on my Facebook page. It's on my Instagram page at HerniaTalk. Wherever you want to find me, you should be able to see a contact us section or an email where you can contact my office. I do offer what's called online consultation. So if you do not live in California and therefore I do not have a license to practice where you are, then you can request an online consultation, send me all of your records. Basically, my nurse will spearhead that, make sure I have all of your imaging and the past operative reports, whatever it is that you have, review it, and I'll figure out what your problem is and help guide you as to the next steps. Next question. Excuse my poor understanding of physics, but can you explain how fixating the mesh at 3 points prevents the mesh from billowing? Is it that the mesh is held tightly enough by the fixation points that non-stretchable mesh cannot billow? Yes. How do I explain this? So if you have 3 points of fixation, then the mesh in between the 3 points is prevented from billowing, and the mesh does not stretch. Okay. So if you have 2 points of fixation, you're only fixating in that one horizontal space, and you're not having any support in the horizontal in the vertical space, and you're not having any support in the horizontal space. When you fixate with 3, then you're holding both horizontal and vertically any movement of the mesh into a defect. It makes sense to me. I don't know. Going back to the Scottish thing, they haven't provided any care yet. They haven't provided any care yet for hernia mesh patients. I heard about that. I believe your skills are moving in here. I am very keen to request the Scottish government reach out for an expert opinion. Absolutely, I'm open to doing that. This then would hopefully start conversations about you helping here. Absolutely, for sure. Thank you for getting me involved with that. Next one, I have a hiatal hernia, which is rather small with few breathing problems. They won't tell you guys. Should I skip it just do the surgery and it doesn't heal on its own anyway? First of all, I don't do hiatal hernias, but for most patients, you must do medical therapy because surgery is not a big deal. You should also get maybe endoscopy to make sure you're not burning your esophagus because you could get cancer. But medical therapy is always considered ideal if for surgical therapy if it's the outcomes are equivalent. While we went through a lot of questions, still more on this. Let's see, here's the question is it's sad that was implemented might always shrink. Not that shrinkage inevitably pull on the surrounding tissue at a time and measures feel them and constantly concentrate. Yes, yes. We didn't talk about pain associated with mesh fixation. The last 5 minutes I'll talk about. So the issue with mesh fixation is just like the bulk of the big parts of what we put the big parts is stated when you just use sutures or tacks, what happens is the mesh is only held in those specific areas. Now, if you put the mesh in too tight, then those areas where it is so in place will get pulled on, which means you probably be tearing whatever tissue is going through, would cause a lot of pain. So one of the reasons why people have chronic pain, their inguinal hernias or ventral hernias, the wall area, is they're actually trying to tear through the tissue, and the mesh was placed too tight. So note that mesh shrinks somewhere between 10 and 25% for most of the meshes, up to 40% for one study that showed for the PTF meshes. So always the surgeon should understand that the mesh therefore needs to be placed with a little bit of give, a little bit of weak of like but it shrinks. Perfect. So, to say mesh, one of the issues is higher risk of chronic pain with either sutures or tacks, but you don't get pain as much or at all really because when you use glue or no fixation. So we are therefore tending towards Velcro or glued in meshes and or techniques such as the sandwiching method that I talked about, where the mesh can be placed without any fixation. Is fibrosis around the mesh and or ingrowth of the tissue into the mesh necessary for the strength of the repair of weak and floppy gerard angle space, or does the mesh itself do the job? No, people who think the mesh itself does the job are incorrect. What the mesh does is it supports the natural tissue. So what you're trying to do for a direct hernia is to tighten that area, that weakness, and make it a flat surface onto which the mesh will then grow and make it more secure and stronger. What a lot of surgeons do is they just put the mesh on top of the weakness. So the mesh is just going to grow into a weakened wall and billow out, or they bridge the weakness, and then the mesh doesn't stick to anything. So it has a very poor function. It's like a wall without any support on the other side. So no, it's the ingrowth into the tissue is part of the purpose of using the mesh and its repair. Let's see, next one. Would chronic pain not be exacerbated by any kind of mesh fixation because the fixation points focalize tension on specific areas instead of the entire mesh surface, and because sutures on the fixation points tear through tissues as the mesh shrinks? Yes. I mean, you basically just repeated what I just said. So yes, you're completely right. Thank you very much. We all know smoking is bad for your health. Could you explain if you feel there's a link between smoking and hernias? Yes. Thank you, Mr. Frenchman, for asking about nicotine use. Okay, so what we know about nicotine specifically is that the nicotine use in itself can disrupt collagen formation. That's why people have wrinkles. So people who use nicotine in all forms, whether it's smoked, patches, gums, that nicotine disrupts collagen formation. So you want your collagen to be placed in this perfect patchy like matrices lines, but when you have nicotine exposure, it actually makes your collagen in a very disorganized manner and therefore not as strong. That's why you have people with bad skin and lots of wrinkles who smoke. The same is true for hernias. So hernias already have collagen problems. So the collagen is weaker collagen. You add on top of that a disrupted pattern of collagen formation, which makes your hernia recurrence higher. So people who smoke have a higher recurrence rate, I believe 7x higher than the average patient. Now, we don't know that nicotine actually causes hernias. However, if you're a smoker and you have a smoker's cough, coughing definitely is a known contributor to developing hernias. You kind of have to have a propensity for hernias already. Nicotine doesn't cause a hernia, but the coughing can cause a hernia. And then lastly, so we got the nicotine collagen issue, you got the coughing if you're smoking the nicotine. And then thirdly, if you're smoking and you're not getting good blood flow, good oxygenation to your wound. If you have a hernia repair and you're still smoking, then the lack of oxygen to the area that is trying to heal surgically will make it so that you have a higher risk of surgical site complications, including infection, and also a higher risk of hernia recurrence because you're not getting good blood flow to the area to heal. So yes, smoking and hernia is not a good combination. Don't do it. Maybe that's going to be a good incentive to quit smoking. All right. Well, my friends, that was lovely. We had a great episode. Talked a lot about how to answer your questions. I'm really appreciative of you. We'll be here again next week. And make sure you follow me on the different platforms. I've been having fun on Instagram lately. If you haven't noticed, I've been putting some funny stuff up on the stories section. So if you like to laugh about hernia jokes, go to Instagram and follow me to follow my stories. I don't really post them so much on the other places, but if you want to learn, go to X at HerniaTalk. If you want to be funny, go to Instagram at HerniaTalk. You want to make sure you don't miss a HerniaTalk episode, go to Facebook at Dr. Towfigh. Sign up for YouTube at HerniaTalk and like and subscribe to my podcast. See you all later. Bye.